I'm a member of the pain team. Very fortunate to work at Salford because I have fantastic nursing and medical colleagues, and we're quite unusual in the sense that we have a kind of a fully integrated inpatient service. So managing sort of complex chronic and acute patients together rather than being at other ends of the hospital, and that gives us, more scope in dealing with these very challenging patients. What I want to talk to you about today, I suppose a few of the learning objectives are really kind of top tips that I've picked up in the experience that I've been in as a consultant. Certainly a lot of the things I've learned from Alison, who's our nurse consultant over the time, who's been invaluable in sort of helping my training and picking up a few top tips. And as Rachel said before, really, a lot of these services work much better when you have the continuity of the nursing staff on the shop floor, 7 days a week. We just sort of flit in as consultants doing other bits of our job, and it's actually the work that the nurses do every day that really makes a department and a service run very well. So not wishing to reiterate a lot of what my colleague Dr Makin said, obviously a lot of my talk is summarised in the handouts, but we're going to talk about neuropathic pain essentially in this conversation. So nociceptive is what we're all familiar with. That's the receptors that transmit information about harm. Neuropathic is nerve damage, occurs central and peripheral level, or you can actually have a mixed picture. So that would be someone who's got a back pain problem and also has a disc and sciatica. So a few definitions. Patients will probably describe neuropathic pain as pain in an area of numbness. International Association of Study of Pain have defined it as some dysfunction of the nervous system, either peripherally or centrally. They've now sort of upgraded the definition. I think it's an excuse to have a meeting in Geneva by a lakeside hotel and talk about things. And they've divided it now into definite, probable and possible. And next year there may well be a definite maybe as well. Okay, so what are the symptoms that we're talking about with neuropathic pain? So patients may well, these are patients we're talking about that you may be coming into contact with on your ward rounds in acute post-op phase. It's not a case of you have neuropathic pain in the chronic pain clinic and you don't have neuropathic pain after an operation. There is a spectrum of patients who have acute post-operative neuropathic pain. The treatment is exactly the same as chronic pain, those chronic pain scenarios. So it's the descriptors that the patients use. So shooting, burning, electric shocks, pins and needles, hyperalgesia, which is an exaggerated or a wound-up pain response in response to a painful stimulus, and allodynia, that's one that Abdul was talking about before, where you brush an area lightly, the patient perceives that as unpleasant or painful. So that's allodynia. And these are some of the terms that patients will describe. So if patients you see post-operatively are having problems sort of verbalising or explaining their pain, if they use some of these descriptors, you want to be thinking about the fact that they may have incurred some degree of nerve damage in either their surgical procedure or the subsequent treatment, such as chemo or radiotherapy that they may have received after their surgery. You may not be surprised to find out that the causes of a neuropathic pain, a lesion, the one I've highlighted here, particularly relevant to this discussion today, this forum, is nerve damage related to surgery. A lot of that sometimes doesn't mean that the surgery's gone wrong. Sometimes it's inevitable that there is nerve damage during the course of surgery. And I'm going to identify a few particular operations associated with a very high risk of developing neuropathic pain and thinking about some practical strategies on how we can predict those patients, identify, and how we can treat them. So neuropathic pain, damage to the nervous system can occur anywhere out in the periphery, which is the blue chart at the top, into the central nervous system, which is the green area. You'll notice there's that sort of chemical soup of inflammatory mediators, and a lot of the conventional pain medication we use aims to reduce that chemical soup that converts those, as Abdul was saying, those chemical signals to an electrical signal. So a lot of the drugs that we are using are trying to modulate pain by calming down that transmission of pain information that goes up to the brain, and we know also there are messages that come down from the brain to the spinal cord that can reduce or alter the pain experience. So overall, the symptoms we get of neuropathic pain are often due to problems essentially with the wiring in the nervous system, hyperexcitable nerves. So when you see a patient in front of you who's proving to be difficult or tricky, or maybe hasn't reached some of the recovery milestones like getting out of bed, walking around, etc., think about neuropathic pain. Does the patient have pain even though there's no obvious tissue damage? Are they using particular descriptors like burning, stinging, electric shocks? Does their pain come and go? Is it there straight away, or has there been a bit of a lag before it came on? And one of the key signs is often neuropathic pain is unresponsive to the conventional analgesics. So you can throw as much morphine, oxycodone, fentanyl at these patients as you want. It's very unlikely it's going to help the pain, and probably all that's going to happen is they're going to end up developing a lot of opiate-related side effects, nausea and vomiting. And as Rachel said before, our experience with our enhanced recovery patients is that opioid-related side effects are one of the biggest factors in patients having nausea and vomiting, which, as we know, delays your discharge by at least a couple of days. We're probably all familiar with this old WHO ladder that was originally validated for treating cancer patients. You'll probably notice that on each rung of the ladder we use this term adjuvants. So the adjuvants are the tablets that I suppose we use traditionally in the chronic pain clinic setting to treat neuropathic pain, essentially either the antidepressant or the anticonvulsant classes. And I'm going to talk a little bit about the evidence behind these. So essentially what's happening is when the pain messages are being transmitted as electrical signals, those packages of chemicals release neurotransmitters across the nerve junction, and then the signal then passes along the nerve into the spinal cord and up to the brain. So the idea of a lot of the nerve painkillers is to reduce the release of these neurotransmitter or these chemical messengers, and that's how things like gabapentin, pregabalin and the antidepressants are working to help reduce the impact of neuropathic pain. So this is the most up-to-date guideline on an algorithm for treating neuropathic pain. You'll notice this is actually applicable to both the chronic and acute setting. You'll notice that if you have a specific localized area of neuropathic pain on the skin, classically from shingles, you can use a topical patch for that. The vast majority of our patients in the chronic, and also the patients we come across in the acute pain setting, will often require some form of tablet medication, be it either of the anticonvulsant class, such as pregabalin or gabapentin, or a tricyclic. Unfortunately, the tricyclic classes aren't particularly well tolerated in the elderly because of the side effects. Okay, so this is an up-to-date slide as well on the NNT. NNT, numbers needed to treat. The lower the number, the more effective the drug is. So traditionally, tricyclics have been used for diabetic neuropathy and post-herpetic neuralgia. An NN2 of 2 means that you need to treat 2 patients to get a 50% reduction in 1. So the lower the NNT, the more effective. The size of those circles reflects the number of studies and trials used to formulate that chart. And that, not surprisingly, Pfizer, one of the pharmaceutical companies who make gabapentin and pregabalin, son of gabapentin, have done a lot of work on that. So that's why there's a disproportionate representation. You may be interested to know that there are some new kids on the block. The Quitenza, which is the capsaicin patch. Anyone use that at all? No? And the one at the top, BTX, is Botox that we use for migraines and tension headaches. It's also used infiltrated into the bladder as well for interstitial cystitis. Now, we are in Salford. We did have Botox that we used to store in our recovery until £30,000 worth of it went missing. And I must say our recovery staff are looking very youthful today. May appear in a car boot sale near you shortly. So the vast majority of evidence is for gabapentin and pregabalin, and we're looking at best one in about you're having to treat 5 patients to get a 50% reduction in 1 patient. That's how we've modified, this came out in the British Pain Society Bulletin about 5-6 years ago. This is how we've modified the pathway. So for mild neuropathic pain, we start off with an antidepressant. We'd consider adding one of the anticonvulsants, either gabapentin or pregabalin to that. And only when it's more severe and they haven't responded to an antidepressant and an anticonvulsant would we consider using, ideally, a modified release opiates. So a lot of my interest in neuropathic pain has arisen because of my kind of surgical background that I did a little bit of before I did anaesthetics. And I was staggered how poor the surgical textbooks were on actually describing chronic pain after surgery. We've all seen it on the ward rounds, we've all seen it in clinics, yet there isn't a lot about it in the surgical textbooks. And it's only really within the last sort of 5 or 6 years particularly that we're recognising the significant issues that people have. This is within complicated surgery as well. This is surgery that's gone technically well, where patients have quite significant problems. And what was really startling was even for something like an elective groin hernia repair, you can have quite considerable chronic pain even a couple of years after the operation. Not surprisingly, operations such as an amputation, thoracotomy and a mastectomy, which are associated with a lot of tissue injury and nerve damage, are associated with much higher incidence of neuropathic pain. Okay, so there's now been a growing evidence base, really, of recognising this problem. And I suppose that leads to the question about, well, how can we, first of all, recognise and identify these patients? Can we risk stratify them? And can we do anything about it? What interventions can we do, be it at the pre-op stage, intra-op or post-op stage, to try and reduce the incidence of chronic post-surgical pain? Rachel's also already touched on our experience in our trust for a few years on enhanced recovery. And we've recognised that clearly what we do, I do as an anaesthetist, but also what the rest of the team do, the surgical team, the nursing team afterwards, does have a key role. And some of the interventions that we offer our patients can have a positive outcome in terms of reducing the frequency and incidence of side effects. One of the latest challenges posed to us by the Department of Health is to try and tackle this big issue of major breast surgery for breast cancer surgery. So the government's aim within the next few years is to try and get about 80% of mastectomies done as a day case. How many people are getting day cases done, day case mastectomies in the hospitals at the moment? No, so it's a work in progress. So it's a significant opportunity to explore, and we're looking at ways of doing that already. Okay, so this is a more up-to-date slide on the incidence of persistent post-surgical pain. This is from 2011. And you can see that we're doing a lot more elective surgery now, particularly according to enhanced recovery guidelines. That pays the books, it pays the bills, pays the mortgage, rapid throughput, reduced length of stay. But there's a very high incidence you can see with things like knee and hip replacements, elective hernia repairs, and we're expected to do a lot more breast cancer surgery, a very high incidence, up to in some cases 50% or more of patients who have persistent pain after mastectomy. And that's not even including the radiotherapy and the chemotherapy that they may receive afterwards. How many of you are giving gabapentin or pregabalin to your patients before major surgery? Could I just see a show of hands? Just a few of you. Okay, right. Okay, again, so there's been an ever-growing evidence base for this in the anaesthetic literature over the last few years. And certainly a lot of the biggest unit probably in the country at the moment, the one up in Hexham, where they've been running a very effective and enhanced recovery service for knee and hip replacements, they've been using gabapentin for a number of years. And the evidence suggests that it may well have some effect on neuropathic pain, but particularly it has quite a significant impact on reducing the amount of opiates that are required perioperatively. And if you remember before, opiates, nausea and vomiting, increasing the length of stay. So there's overwhelming evidence from a variety of studies, admittedly mostly done by the same author, that gabapentin is effective given preoperatively, if not to reduce neuropathic pain, but to reduce opiate consumption. And I think the question of whether some of the medication we can give to patients before an operation to try and reduce nerve damage and to reduce neuropathic pain is an unanswered question. So it's a watch this space. Again, as pregabalin seems to have become quite fashionable, it seems to be taking over the position of gabapentin because it's taken twice a day rather than 3 times a day. Again, a growing base of evidence and literature concerning its use, and primarily the opiate sparing effect it has, and also arguably it may well be better tolerated in some patients than gabapentin. Patients prefer to take a medication twice a day rather than 3 times a day. So let's concentrate on some specific types of surgery that we know are associated with high risk of neuropathic pain. So a lot of literature out about breast surgery. So there's some interesting developments. Paravertebral blocks, if they're started beforehand, can reduce not only post-surgical pain, but also very interestingly can actually reduce recurrence rates by 5 years. No one yet knows how that happens, but I think it's very interesting that some of the things that we do nowadays may well have an influence on long-term outcome. So clearly there is a role for some of the neuropathic agents as well. So venlafaxine, which is a less frequently used antidepressant, now it's probably used more in the States than it is here, if that's given to patients preoperatively and continued in the perioperative phase, that can reduce pain on movement at 6 months. Gabapentin can reduce some of the burning elements of pain, and then some of the topical local anaesthetic creams can also reduce the allodynia and the neuropathic pain associated with a mastectomy scar. Joint replacements, we're doing a lot more of these now. We're going to be seeing a lot more as we get our enhanced recovery pathways up to speed in orthopaedics. So there's a chap in Chicago at the Rush Hospital. His data suggested that up to 15% of patients have persistent pain after a routine knee replacement, and this is one that's gone well. This isn't a complicated knee replacement. By giving those patients pregabalin immediately before the surgery and continuing during the surgical phase, you can actually reduce that down by half. Again, so that's a encouraging messages that what we do as a pain team can actually modulate and influence outcome. So how do we go about identifying some of these risk patients, some of these heart sink patients that you may see post-operatively? Clearly it relies on quite a bit of teamwork, identifying the most appropriate patients to operate on. And clearly there are some high-risk patients. For instance, we have a lot of surgical patients with chronic pain on high doses of opiates, and you can sometimes get a feeling beforehand that these guys just aren't going to do very well. We set up what our clinical director calls a spinal factory, with the idea of doing day case disc surgery. Hasn't gone as well as expected. We've had a few people staying in for 2 or 3 weeks because of chronic pain problems. Bless you. It's very ladylike, by the way, very polite. So we know it's a complex thing, post-operative pain. So it's part of the continuum, it's part of the process. There are things that we can identify about these patients beforehand. Something in their wiring, in the way they cope with things, their anxiety levels. Interestingly, we know that if we get patients to sleep better beforehand, if we get their sleep architecture sorted, that has a significant impact on reducing their pain and their opiate consumption post-operatively. Things that the surgeons can do to influence outcome. We know, as Rachel said before, the laparoscopic surgery, less physiological and pathological insult, less tissue damage, less pain, so quicker recovery. Things that we do as anaesthetists, we're doing far more nerve blocks, plexus blocks, etc. for orthopaedic surgery. That reduces the amount of morphine and allows us to accelerate recovery. And lots of these other interventions that we do are aimed at reducing the incidence of this persistent or chronic post-surgical pain. Clearly, as Abdul said before, there are a whole load of things happening in the nervous system, out in the periphery to the central nervous system. That's a diagram merely illustrating that there are lots of chains of command where nerve damage can occur and how pain is processed before it's actually perceived in the central nervous system in the brain. So what are some of the risk factors that are there? Well, not surprisingly, patient-related factors, so coping skills, anxiety levels, needs to say the type of surgery and is it revision surgery, sex, higher incidence of post-operative pain in female patients, I've no idea why yet, and then obviously other ongoing things as well, so other treatments patients may receive after their surgery such as chemo and radiotherapy. What other factors are likely to predispose or increase the incidence? So it's not only the nature of the surgery, the type of the surgery, but also things like, if you don't get on top of pain in the immediate post-operative phase, that's likely to cause problems long term. And, identifying all these psychosocial factors, how to tackle distress and anxiety in these patients beforehand. Is it worth us investing more time and effort in the pre-op clinics, maybe getting these patients to see a psychologist, trying to match their expectations, and will we reap the rewards for that in the long term? Again, that's a work in progress, and certainly there are some plans afoot to get psychologists, involved in peri-op care, but that's a work in progress. So a lot of patient factors that we can identify in these patients, and this has been reproduced in all kinds of surgery. So there's a lot of literature, particularly on looking at outcomes after lumbar spine surgery, and we know that if we offer these patients some low-level psychological interventions to reduce their anxiety, improve their sleep, give them more positive spin on things with cognitive behavioural therapy, that can improve their experience in the operative phase. And again, we like scoring systems as doctors, particularly anaesthetists. This is a risk prediction. It's in your handout. So basically, if you have score more than 4 out of 15 in this would suggest that your patient is at risk of having persistent pain post-operatively. So what we've done, this is a chart that was done by one of our pain nurses, Martin, who spoke earlier on today. This is the chart that we developed within our centre that was used for this radar acute pain project a few years ago. So this is available, or a modified form of this is available in the pre-op clinics, and the idea is that we try and identify at-risk patients in the pre-op phase so that our pain nurses and other members of the pain team can review the patients and try and formulate a plan for their analgesia at the time of their operation to try and allay a lot of their anxieties and fears, particularly if it's someone who's coming in to have revision surgery who's had an unpleasant or an unfortunate experience previously. And then this is a pathway that Dr. Turner and Sister Dwyer have developed a few years ago. This is our difficult pain pathway. This is what we use in extremis when we're in recovery. This is for fighting fires. Admittedly, it's a good idea not to light the fire in the first place, but when you've got a patient who's in agony, in recovery, who's not responding to their PCA, whose epidural hasn't worked or their nerve block hasn't worked, this is how you can get yourself out of a tricky situation. So considering, opioid-sparing things like non-steroidals and paracetamol, considering another alternative opiate, so if you've been using morphine, you might want to use fentanyl instead, considering the role of introducing something like gabapentin, which is opiate-sparing and can help reduce some neuropathic pain, and then thinking about things like ketamine, clonidine and magnesium as well. So you can use that, potentially you can use that in your trust if you wish to develop that. So again, one of the other things that rears its head when we're having a discussion about pain and perioperative pain is there a role for preemptive analgesia? This is an argument that's been kicked around for about the last 15 years. No one's ever been able to reproduce the piece of work done on epidurals, cited 3 days before an amputation reducing the incidence of pain. No one's ever been able to reproduce that, whether there were some methodological flaws in the way that was set up. But clearly it's a question that needs to be answered, and it's still relevant today. So if we look at the evidence, this is from the Australian Acute Pain Handbook that you can get through the British Pain Society. So there is overwhelming evidence that some of the interventions that you can do are worth doing before the surgeon gets anywhere near the patient. So if you have local anaesthetic infiltrated into the wound before the surgeon puts a knife to skin, again with epidurals, things like ketamine before the surgeon operates, that will reduce the amount of morphine and hopefully reduce the incidence of chronic pain. So it's not necessarily saying it's preemptive, but it's certainly reducing the impact of pain, and indirectly using morphine use as a proxy measure, you're using less of that, and again that causes a lot of the side effects. So in summary, what do I want to be saying? What are the messages I'm trying to give you that I want you to take home today? Well, we know that pain is a very complex entity. There are a lot of patient-related factors, surgical factors, anaesthetic factors, and a lot of factors really to do with, pre-operative anxiety, catastrophizing. Clearly, a highly distressed, anxious, wound-up patient, not surprisingly, is probably going to have a worse outcome than someone who's been fully informed and had all their options discussed in a pre-op clinic. Faulty wiring. Patients, is there a genetic predisposition? Nerves get damaged. When nerves are damaged, nerves misfire, can produce chronic pain, neuropathic pain. And also, we can predict these patients. There is an inevitability. Certain types of surgery are associated with persistent post-surgical pain, top of the list being amputation, mastectomy, and knee replacement. And when you're seeing or encountering these patients, don't be surprised if they're struggling post-operatively. So the question is, are there things that we can be doing to reduce the impact of pain and reduce long-term pain after surgery? And I'm happy to take questions, and there's already one there. Yeah.
How long do you carry on the pregabalin or gabapentin? Because I start them a couple of days before when they see in pre-op. But how long then do you expect to carry on?
That's a very interesting question. Again, if you read some of the literature and you hear the experience from the group in Hexham, who've got very good results, they were carrying on things like gabapentin for the rest of their inpatient stay and occasionally taking gabapentin home with them. The feedback we got from the wards, however, is that if you have a frail 80-year-old lady who's just had a knee replacement and she's suddenly taking 300 milligrams of gabapentin that you've given her, you're kind of swapping the opiates for the gabapentin, they get dizzy and they start falling over. So we're mainly concentrating on the pre-op dose to try and reduce some of that chemical soup and transmission of pain. And then it's a question really of, if that is well tolerated, it might be worth thinking about reintroducing it, but patients don't routinely get it post-operatively because of the side effects.
Pre-op dose?
Again, the evidence is that the higher the dose, the more effective. The problem is the higher the dose, also the higher the chance of sedation, dizziness, etc. 600 is probably the bare minimum dose. Doses less than 600 milligrams are probably homeopathic and probably aren't doing very much. So at least 600 milligrams. Ideally, if you can have a dose the night before, you sleep like a baby, and then 600 milligrams the morning of.
And of the pregabalin and gabapentin, any preferences?
I couldn't possibly say.
Yeah. We do have a preference. Yeah. Gabapentin, because it's cheaper. So if there's a Rapid Pfizer, it's pregabalin. Gabapentin, because there isn't a good evidence base between the two. And Cadet is one of the, when he talks, one of the streams of work that he's looking at is dosing. Because there isn't good evidence, is there, for dosing preoperatively, and there isn't a good evidence for how long you should carry it. There's good evidence it works, but all the trials are different.
Regarding the neuropathic pain ladder, treatment of ladder, you said antidepressant first and then introduce anticonvulsants. but sometimes in inpatient settings, the antidepressants take quite a long time to be effective. So would you suggest starting anticonvulsant first?
Yeah, I think that's the sort of modified ladder. I suppose applicable in a chronic outpatient setting and also an acute setting. You're quite right. The time scale for that, antidepressants do take a while to work. They're cheap. There's good evidence base for them, not in elderly patients. We would probably be a bit more aggressive in terms of introducing adjuvants for patients who are in the acute phase with neuropathic pain. So we'd probably start some gabapentin first line in a moderate dose as well, 300 milligrams TDS. In an outpatient setting, clearly I suppose your goalposts are slightly different, and you're quite right, the biochemical changes induced by antidepressants do take a while, restoring noradrenaline and serotonin to reduce those downward messages from the brain to the spinal cord. Yeah, thanks for raising that.
What does magnesium do in the acute setting then?
It's just magic. No, it blocks the sensible answer. The doctor answer would be that it's a physiological antagonist of calcium. So it reduces calcium channels, calcium influx. A lot of the pathways, a lot of the sort of pain transmission is mediated by calcium channels. So you get calcium going in through your calcium channels that then releases lots of neurotransmitters. The theory is if you block the calcium channels with magnesium, you hopefully kind of reduce some of the other effects of that. There's good evidence. I mean, magnesium seems to be a bit of a panacea. It's used in all sorts of things. It's anticonvulsant. It's used for bronchospasm. We use it in atrial fibrillation. It can be quite effective when we've used it in the recovery. The top tip is that you actually need to inject it quite slowly, because if you give a big 50 ml bolus straight away, it really smarts when it goes in. So it really reduces calcium channels and neurotransmitters.
What is the dose in that setting for?
8 millimoles we give. 8 millimoles in a 20 ml syringe, and we probably give it as an infusion over about 20 minutes.
It not depends on the patient's pre-operative. Normally, we are not, doing the magnesium levels in every.
No, we're not. No. I mean, this is just like a rabbit in the hat in recovery. Mm-hmm. So the recovery nurses think you're wonderful, don't you? Mm-hmm. You're still sulking about the Botox, aren't you? Sorry?
And it's not our fault. I'd have to say, when we wrote the pathway, we looked at what everybody does in terms of emergency analgesia in difficult patients in recovery, and we looked at everyone's practice, and we looked at the evidence basis for those. And if I were to tell you what my favourite would be out of all of those, in those patients who are difficult, I would go for the clonidine as my first line. Other people go for the ketamine, but I certainly would go for the clonidine if they had a bit of hypertension, because I think it acts much better. But some people do use the magnesium, so we put it in there. The evidence base for the magnesium, I personally don't think it's as good as it is for the others, but they are all recognised treatments for difficult pain. So clonidine, ketamine, magnesium, further dose of gabapentin, further dose of paracetamol.
I think the clinical favourites now are definitely ketamine and clonidine. We don't see as much magnesium anymore.
And what about the dexmedetomidine?
Okay, dexmedetomidine is, well, it's not really available to us, so we use clonidine. So I don't know if dexmedetomidine is. Dexmedetomidine is available in our hospital for sedation in patients having a wake craniotomy, and that's our only license for it, so we wouldn't be able to use it. So I haven't got any experience, so I can say.
Thank you.
Yeah, sorry, question about that. Yeah,
what's your position on the use of tramadol in the management of neuropathic pain? Do we need a dual action of...
Yeah, and it's got some quite attractive properties because it's a dirty drug, isn't it? So it works on opiate receptors, it works on noradrenaline and serotonin. The problem is, I think the limiting step is its side effects. It's not particularly well tolerated in the elderly, and I know kind of son of tramadol, this drug called tapentadol or Palexia, supposedly has some more attractive features and less side effects. It has been incorporated into the neuropathic pain algorithm. That's a sort of universally European agreed pathway. So there clearly is a role, but as with anything, it's not just the NNT, it's the NNH, it's the numbers needed to harm. It's not well tolerated in all patients. A bit like Marmite, you either love it or hate it. We don't tend to use, am I right in saying, Sister Dwyer, that we don't use a lot of it, do we really? Acutely. Not acutely, no. But you might hear, some of the enhanced recovery units elsewhere swear by oral tramadol, and they prefer patients to have that than Oromorph and Oxynorm, and it may well work in their particular population groups.
It has a side effect of hallucination, and also the problem with the renal patients, and the impairment of the kidney function as well.
Yes.
So these are the real problems.
Yeah. You're determined to get in that microphone, aren't you? You will have this microphone.
My voice is not...
Sorry, what was your question? I couldn't hear you. Can you speak through the microphone? So, yes, you're right. So, I'm not saying that tramadol's wrong. It's just... It just, doesn't suit everyone, really.
Balance.
So,
if your patient is young, then you can...
Yeah, you probably get away with it,
Thanks.
Of course you can.
In our hip and knee replacements, we use just gabapentin. As an inpatient, is that not going to be as effective?
That's fine. As I said, we started in our kind of rudimentary enhanced recovery pathway, including gabapentin as the... Where are you from, by the way? Sorry.
The Alexandra in Cheadle.
That's right. Okay. Sounded embarrassed about it. It's all right.
No, not at all.
Did they get it like on a silver platter there at the Alex? Is that before soup or after? It can work very well for some patients. The problem is most of our 8-year-olds were off the tits on it, so they were all falling over. Sorry, they were confused and cognitively impaired on it, so we stopped doing it. Basically, a lot of the feedback we get is from the OTs, the physios on the ward. So we stopped using intrathecal diamorphine in our... I know that Rachel was talking about it for colorectal surgery. We've literally stopped giving intrathecal diamorphine on all our hip and knee replacements because they look fantastic in recovery. The problem is the next day they're really, really dizzy. The men are in urinary retention, they're itching, they're nauseous, and they get... Is that right? Can you back me? Yeah, and they're really dizzy when they stand up, so we've stopped giving them that, and we rely more on local anaesthetic things. We thought we'd get really good figures with using gabapentin intraoperatively, perioperatively, but they were having real problems taking 300 milligrams of gabapentin or even 600 3 times a day. So we've literally cut it down.
Right. I thought gabapentin takes a while to...
Yeah, I think the way... I said, hopefully showed on the evidence, and it is in the handouts, but you are producing opiate sparing by giving a dose preoperatively, so you can reduce your opiate requirements by up to 50%. And I think we're all agreed that the opiates are the things that cause a lot of the side effects: nausea and vomiting, delayed discharge. No one can really establish what effect it's having on neuropathic agents. That's why I raised the issue about preemptive analgesia. Will it reduce the magnitude of the insult by giving the medication beforehand? No one can actually answer that. And as Justin said, lots of different study designs that aren't necessarily particularly robust. But in a chronic pain setting, if you've got neuropathic pain already, it'll take a while to get it going. The idea is giving these patients $1 per gabapentin before the surgeons get the grubby mitts on them. And then hopefully reducing the nerve... Sorry, no surgeons in the room, are there? Good, right, okay.
I want to just put my 2 pence on the gabapentin.
Well, you normally do anyway, so carry on.
Because I think one of the things with gabapentin, and it's obviously being peddled now as part of enhanced recovery, particularly in orthopaedics. We do use a lot of gabapentin in the service, but I think you have to be careful on the patients you pick. It's no panacea and it doesn't suit everybody. And when we've tried with our orthopaedic patients, I think what Rick's just been saying, we have had problems with patients being sedated. We have had problems with not being able to mobilise patients because they felt dizzy and not being steady on the feet. So I think we've got to be careful about patient selection with it, because it is a great drug when it works. It's a fantastic rescue drug in recovery when we're struggling with some of the other things that we're using. And when we do then you introduce it post-operatively if it's tolerated, and we'll monitor that just for a few days. But it has, you know, we've had our fingers burned with it a few times with patients because it's just not suited them. And certainly I know of experiences in other hospitals where they've introduced it blanketly to, you know, as a pre-operative drug. That again, that's been a big issue, respiratory depression and difficulty mobilising patients post-operatively. So it's got its place, but we just really need to be careful about patient selection. We don't know the dose, is the other thing, so that's the other problem.